you.
Kia ora koutou. It's lovely to be here again. It feels like coming home. slightly kind of Twilight Zone-ish, actually. I'm Diana Sophie, for those who don't know me. I was the immediately prior head of department. I'm now chief executive of the Cancer Control Agency. And Sophie, I met Sophie actually when I was working at IARC, the International Agency for Research on Cancer, the first part of my sabbatical in 2017. And she was doing some work on comorbidity, and she was doing some work on this kind of stuff as well, cancer among older people. So we ended up talking a bit. And anyway, long story short, she got a grant to come and work with me here in New Zealand, and then she's doing the second part of her fellowship in Oxford, which is equivalent, obviously. And basically she arrived and I left. She's been trucking along on her own. So it's really, this is the first time she's presented this work. So she's a bit nervous. So I said, all you do is you just do the whole presentation in French and you won't get any difficult questions at all. So we'll see how she goes. I'm sure she'll be fantastic. Sophie.
Kia koutou. Thank you, Di, for the introduction. But I want to say that I was lucky to come this year and to see the creation of the Cancer Control Agency. And fortunately, I was here as well for the pandemic. I think it was the most safe place in the world, at least better than in France. So probably after thinking a lot about that, it was probably the best year to come. So I'm Sophie Pilleron. I'm cancer epidemiologist. And I focus on older adults. So I'm going to talk about cancer in older adults, with a focus on age disparity in cancer survival. I don't know if it's okay. You can hear me? Perfect. Let's go. So first, I will describe the epidemiology of cancer in older population worldwide, and I will do a quick focus on New Zealand. I will then tell you why older adults need specific consideration. I will talk quickly about cancer survival metric before moving to the description of age disparity in cancer survival, and I will take the example of colon cancer. In the last part, we will see if we can improve outcomes for older adults. Let's start with a bit of epidemiology. In 2018, 18 million cancer cases were diagnosed worldwide, all age combined, and 36% of them was over the age of 70. If we assume that the cancer incidence rate will remain the same, in 2040, there will be 29.5 million new cancer cases worldwide, and 45% of them will be in adults over the age of 70. This increase will be seen in every world region, even the less developed one, such as Sub-Saharan Africa. And obviously, this increase will challenge healthcare system worldwide. Lung cancer is the first most common cancer in older patients, followed by prostate cancer and colon cancer. Breast cancer ranked fourth and stomach fifth. In New Zealand, about 36,000 new cancer cases were diagnosed in 2018, and 42% of them were in older people. In 2040, it will be around 52.5 thousand new cancer cases, all age combined, and 56% of them will be in old people. The most common cancer in older people in New Zealand are quite the same that globally. So prostate cancer came first, followed by colon and lung, and breast cancer ranked fifth. Now that I gave you a glimpse of the current and future burden of cancer, I will tell you why a specific focus on older adults. Older patients have peculiarities that impact cancer management. Because of the age-related physiological changes, comorbidity, and polypharmacy, older adults are at higher risk of drug interaction and chemotherapy related toxicity. Also, depression is very common in older patients, and often they are isolated with poor social support that may complicate the cancer management. Hearing loss or cognitive impairment may also impede communication and ultimately cancer management. And as other patients, cancer patients undergoing chemotherapy often experience peripheral neuropathy that cause disturbance and increase the risk of falls. And falls in older patients can have dramatic consequences. Altogether, in brief, cancer management in older patients may be very complex. On the top of that, older patients are seldom included in randomized clinical trials, meaning that physicians have to extrapolate from evidence based in younger patients to adapt a new drug to older patients. There is a quote that summarizes perfectly the consequences of the lack of inclusion of older adults in clinical trial. It's a quote from Dr. Moile from the US. She is a geriatric oncologist, and she's often interviewed about cancer management in older patients. And in one of her interviews, she said, "We harm and then we adapt." I found this sentence very terrible, unfair, and scary. Fortunately, this is changing slowly with some new guidance and recommendations from the FDA on NIH to encourage the inclusion of older patients in clinical trials. The treatment period is obviously a period when age disparities occur. Evidence shows that older patients have a lower likelihood to receive surgery or chemotherapy than younger patients. They are also at higher risk of chemotherapy-related toxicity and post-operative mortality that can last for 1 year. As a consequence of all that, older patients with cancer have poorer cancer survival than middle-aged patients. I will make a slight digression here to define what I hear by survival, but I'm not going into detail. It's just to help with interpretation of results that follow. Obviously, older adults have higher risk of dying than younger adults. So it doesn't make sense to compare overall survival between middle-aged patients and older patients. What is interesting is net survival, that is the probability of being alive beyond a defined period of time, let's say 3 or 5 years, in the hypothetical world where we can die only from cancer. So we remove all the other causes of death, and so that we can compare both groups. So if net survival is not the actual survival that a patient can expect, it's probably lower than net survival because obviously we can die from other causes than cancer. I wanted to, it doesn't work. The main advantage of this metric is that it takes into account competing risk of death, and we can make comparison. So as I said, older adults have poorer cancer survival than middle-aged patients. Here I give the example of colon cancer. This figure represents a 3-year net survival by age at diagnosis in 7 high-income countries, including New Zealand. As we can see, the colon cancer survival decrease as age increase, similarly in all countries, everywhere. Actually, older patients do not have always poorer cancer survival than middle-aged patients. For instance, here this shows a net survival for over 3 years. For colon cancer by stage, localized, regional, and distant, for different ages, 55, 65, 75, and 85 years old. what we see is that survival in localized cancer is about the same regardless of the age at diagnosis. However, the age difference in net survival is increasing as the disease spread. Stage at diagnosis is obviously an important factor of age disparity in colon cancer survival. When we look at the excess mortality hazard that drive survival, we observe that in localized cancer, the excess risk of death is very low, whatever the age at diagnosis, explaining why there is barely no age disparity in colon cancer survival. For regional cancer, the excess mortality in older adults is concentrated in the first 6 months after diagnosis. This is the period around treatment. There is another peak here around 15, 18 months that may correspond to an excess mortality related to complication, surgery, or chemotherapy. For distant cancer, the excess risk of death among the oldest patients is evident during the first 18 months, something like that. It's also probably because of under treatment or higher complication from treatment. Helen Gower and myself reviewed the literature to see if there is other factor influencing age disparity in colon cancer survival. Out of more than 2,000 references, we retain only 16 studies on colon cancer. What we found is that while age at diagnosis is an important prognostic factor in cancer survival, very few studies, often of suboptimal quality, have specifically focused on the relation of age and cancer survival, and none have sought to identify the factor of age disparity per se. However, our review showed that there is a great the magnitude of age disparity differ greatly based on patient and clinical factors. Second stage diagnosis was consistently found as a factor of age disparity. We found some studies about treatment, but they were at a very high risk of bias. We couldn't conclude anything from that. So because we don't know anything, there is very few evidence on age disparities. So I conducted my own analysis, and I use the colon cancer survival data here in New Zealand that I linked to hospitalization data to look at the potential effects of several patient-related and clinical factors on age disparity. Briefly, I included patients with colon cancer diagnosed between 2006 and 2017, age over 50, and I look at the effect of sex, ethnicity, deprivation, comorbidity, and emergency. I fitted a model by stage at diagnosis using flexible parametric hazard regression model. I will just focus on regional and distant cancer because, as we saw, there is no difference, age disparity for localized cancer. So we observe no difference in survival between female and male patients with regional cancer. However, we observe an interaction between sex and age for distant colon cancer. Female patients aged less than 65 years old had better colon cancer survival than men. After 65, the tendency is reversed. As a result, age disparity in a female patient was greater than in male. The explanation for that is not clear. It could be explained by the involvement of sex hormone, or also it could be just the alterations found by chance. So we don't know, it needs to be further investigated. Regarding ethnicity, as known, Maori patients have poor cancer survival, whatever the age, but ethnicity didn't change the age disparity pattern. Deprivation, so cancer survival is decreasing with a higher level of deprivation, but again, deprivation doesn't seem to play a role in age disparities. Overall, patient-related factors don't play a major role in age disparities in colon cancer survival in New Zealand. Because comorbidity is very common in older patients and it influences greatly cancer management, we were assuming that comorbidity will be one of the factors that may influence the most age disparity. Actually, it's not the case. Comorbidity did not explain age disparity in our data set. And as you can see, there is little difference in survival across comorbidity levels. In contrast, the fact that the cancer was diagnosed within the 28 days following an emergency admission influenced greatly age disparity in colon cancer survival, but differently in regional and distant cancer. In regional cancer, the age disparity was the greatest for the emergency group in blue compared to the other one. For instance, the 1 year net survival was 96.5 in patient age 60 and 93% in a patient's age 80 years old. The difference was 3 points. And in the emergency group, the difference was 13. Sorry. In distant cancer, the age disparity in colon cancer survival was a little bit greater for the non-emergency group, as we can see in the difference of the first 1 year net survival between patient age 60 and 80. It was 90 in the non-emergency group and 66 in the emergency group, but the difference is very, very small. Our result suggests that the most important factor of age disparity in our data set is timeliness of cancer diagnosis as assessed by stage of diagnosis and emergency presentation. And in this last part, I want to be a bit optimistic. All other adults are not like that, frail or vulnerable. Some are like that. Some are able to run an Ironman, as Jan Miller did at 70 years old, or some are stars on Instagram at 92 years old. And our French world oldest competitive cyclist at 108 years old. Just, wow, incredible. Well, honestly, most of other patients are in between these two extremes. So we have to be able to distinguish people to distinguish frail patients from fit patients. We have to somehow assess the physiological age, and we know that age is not, age alone is not a good proxy of physiological age. So age cannot be the only factor to take into account when decided about cancer treatment. Health provider and oncologists should be able to screen vulnerabilities in older patients that may impede cancer management. However, they often fail. Very recent studies show that in 100 patients accumulated 356 abnormalities, 73% of lack of people with lack of functional status were not identified by the provider. It was 86% of lack of social support that were not identified by the provider, and 44% of nutritional deficiency and 96% of the cognitive impairment. There is cumulative evidence that a comprehensive geriatric assessment may improve cancer outcome in older patients. This assessment should take into account the life expectancy, obviously, of the patient, but also their general fitness, their physical and cognitive health status, and their nutritional status. Should take into account also the social support. Is the patient is fully independent, or does the patient need doesn't he need help for daily activities? Does he have someone to take care of him to go through the treatment period? All these questions should be asked. And based on the vulnerabilities identified, we can propose some interventions such as nutritional counseling or physiotherapist session to improve the gut balance, of psychiatry, referring to a psychiatrist in case of depression, and so on. Geriatric assessment is not a new concept, but it entered in the cancer field a decade ago only. There are myriad of studies using observational data that have shown that geriatric domains were associated with poor outcomes in older patients with cancer. But this is only this year where the first result of clinical trials came out in the 2020 American Society of Clinical Oncology meeting. In brief, geriatric assessment improve patient-provider communication. The combination of geriatric assessment with appropriate intervention reduce the severe chemotherapy-related toxicity, reduce the number of unplanned hospitalization and the number of emergency room visits. Older patients are less likely to stop their initial treatment early, and it improves quality of life. It's quite easy to implement, but it involves geriatrician or a geriatric oncologist. There is no matrix here, so I forgot the conclusion of the slide. There is no evidence of interventions that can effectively improve cancer survival in older patients, but the implementation of geriatric assessment will probably improve the quality of care and the quality of life. And this is probably the most important thing where in older patients, it's better to add life to years than to add years to life. To conclude this talk, here are the take-home messages. So older adults make up the most cancer cases and they experience a poor outcome. But even if it's utopian to believe that the cancer survival in older adults will equal cancer survival in middle-aged patients, I truly believe there is still room for reducing age disparities by reducing delays in cancer diagnosis and by implementing geriatric assessment-driven intervention to reduce poor treatment outcome and improving the quality of care and the quality of life. Thank you for your attention.
Thank you so much, Sophie. That was absolutely fascinating, and it's really exciting seeing this work progressing. As you know, it's an area of great interest of mine, but I will open the floor for questions.
Is it working?
Andrea's got one.
Thank you, Sophie. That was really interesting. I'm Andrea from Public Health. So I'm just wondering if, from the information that you've just presented, it seems like that a really simple fix to start with would be health promotion within the communities, so that families are aware of, to encourage these routine checkups with the doctor, and because it seems like from what you've said that there's, especially in women, at the retirement age, their risk increases, which could be something to do with detaching from community and kind of less self-care. And I'm just wondering is there any information around if health promotion would be useful?
I haven't looked at that yet, but it's an interesting point, and I guess, yes, it deserves to be looked at. Thank you for the idea. Sorry? Yes, but it's not only about women, but you know, the order, but I don't know if we can really choose this interaction yet. But yeah, they are doing better when they are young than men. And after, there is probably also a survival effect. So it's difficult to know because it's just descriptive study. It's just what we observed. There is no causal things behind. So yes, it's just to be interpreted with caution.
I've got a simple question. For the emergency department presentations, were they presentations for any reason or for reasons that related to what became the cancer?
No, in this analysis, it was for any reason. So it could be, yes, we could have, sorry, I don't know how to say that, but yes, it was all. And most are 23% of this emergency admission occur within the seven days prior to the cancer diagnosis. So this 23%, it's almost sure that it's related to cancer stuff. But 28, it's usually what it's taken as period. So. But it's true, it should be looked at further as well.
Sophie, a question from me, Philippa. Thank you for a very clear, interesting presentation. And you've had an opportunity to work in France, New Zealand, and obviously connections with England. I wondered if you would like to reflect on the nature of cancer services in the countries that you've worked in. And you're leaving soon, I understand, sorry, but so you can say whatever you like.
Very interesting question. I'm a baby in cancer field, so I don't really work in France. I was more working at IARC, but at international level. I don't know yet the system in UK, so I can probably come back and do this comparison in another.
Which is part of the point of the fellowship.
Yes, it's part of, it's to see if the same thing is seen everywhere. I just take New Zealand and UK, but in the near future, I hope to do the same work in other countries in Europe. And yes, it's something interesting to look at. But as we saw in the ICBP project, in the 7 in high-income countries, we will probably see the same things everywhere because we see the same pattern in each country. But I cannot tell you more now. But I will come back and we can have that discussion. Thank you.
I think this work raises a sort of a broader issue around the way that cancer is treated, and what has tended to happen is cancer is treated in a silo. Someone's diagnosed with cancer and then the focus is very much on the cancer rather than on all of the elements that might be affecting a patient. And it's probably most marked in older patients. It's most obvious, but it's relevant for all patients. It's also relevant for looking at ethnic inequalities, for example, and actually thinking about that, the age at which these issues might be problematic is likely to be younger in some ethnic groups. Kevin and I have done quite a lot of work on cancer and comorbidity, just to see if there's anybody else here from that work, but not so much. But, you know, thinking about exactly those things, haven't we, Kevin, about trying to unpack what else might be going on for people. So I think it's really important work and more broad than just for older patients, but most relevant for them.
Obviously.
Any last questions? Well, oh, sorry. That was roll. No, go on and ask.
Just going to ask, so obviously that was Really awesome talk, by the way.
Thank you.
So that was a really descriptive stuff that you've done, as you were saying. Have you ever looked into or thought about looking at more qualitative research surrounding older adults and cancer diagnosis?
It's one of my plans. Because there is no, the interest in older patients with cancer is not, it's quite recent. There is no, and even if they are constituting the most part of cancer diagnosis in the future, yes, there is little attention on this particular patients. So yes.
And interestingly, we tried to put a clinical trial together to look at this actually among patients with comorbidity, but very similar principles about 5 or 6 years ago in New Zealand, and it was very, very difficult to get funding because it wasn't kind of sexy. You know, it was a wraparound intervention as opposed to a drug, or it was really, really difficult to kind of get the traction that we needed, which is annoying because, you know, the studies have only just come out, so that would have been the first, which we knew at the time was going to be the first RCT evidence, and we suspected that the results would be as they have found to be. So it's good that that evidence is starting to emerge. So with that, I will thank you so much, Sophie, for that presentation. It was a really good presentation. It was really clear and really interesting, and I will be keeping this in mind in terms of health cancer services in New Zealand and how we implement this kind of work here. And good luck with your travels to the UK. When are you leaving?
No, I go to France first.
France first.
Yeah, I'm not sure to go to the UK.
Oh, no, exactly. It's slightly alarming at the moment, but it's been fantastic having you here. I do apologise for not being around as much as I would have liked to be.
I think, as I said, it was probably the best year, and I could see the creation of the agency, so
That's true.
it was
That's true.
for a good reason.
Yeah. Well, thank you very much, Sophie.